So I think in the next 30 or 35 minutes, I think I would like to say a little bit about the cardiovascular disease risk factor, which I think is still underscored triglycerides. And this is the agenda of this afternoon. Perhaps we cannot cover everything. First, is it a risk factor? People are not so convinced, or the physicians, because people who work with me have seen that most of the troubles we have is people who are referred for triglycerides, and over again they run around and nobody has done anything. Diagnostic techniques, and if I say the diagnosis of hypertriglyceridemia, fasting versus non-fasting, because there is still a kind of a myth that everybody, when you check lipids, is the most unphysiological condition, that at least the last 8 to 12 hours you do not eat. That's very rare, and of course your vessels are then exposed to a concentration which is not the reality. I will not say nothing regarding the genetics, the triglycerides and cardiovascular disease, and then very short regarding the treatment. And you are all convinced we need randomized controlled trials to see if the medications which lower triglycerides are in fact also reducing morbidity and mortality. That's a kind of cartoon regarding the triglycerides. Triglycerides are very much involved in inflammation, and if we look, triglycerides, so you have the HDL particle, the LDL particle, the VLDL, and the IDL, so what we would call the remnant. And what you see is in the IDL, the VLDL is mainly filled with triglycerides, while the LDL is mainly pure with cholesterol. So the white is, and of course the microns is with triglycerides. Triglycerides will induce inflammation, then promote also atherosclerotic disease. I think most of you know the classification of Fredrickson. You see here the phenotypes of hyperlipidemia, and despite nowadays everybody talks only regarding LDL, you see from type 1 till type 5 that mainly always triglycerides are significantly elevated or even high. Like type 1 more than 2,500, type 4 and 5 similar. So I give you a little bit of historical flavor regarding the difference Europe versus the US. Why in the US there is much less attention for triglycerides? Because most of the work started in Europe, and the Germans, they were very early to do in the at the University of Munster. Assmann, he was very interesting, but the poor guy was not taken seriously because he could not compete with all these guys who did research of cholesterol. He was always put as a kind of a last speaker on any lipid events because it was all LDL. And then at the final end, he got so upset that he said we need to have a very good study. He applied to the German government, like here the NIH, he got it. It was called the PROCAM. And then he published it in 1992 that indeed, in function of the triglycerides, even from the level 200, that the events for coronary artery disease increased. And this was a little bit the stimulus for the research at both sides of the continent. And in the meantime, Framingham was also looking to their data regarding coronary heart disease risk, male versus female, because what they figured out was they got very puzzled that in female, of course, there was a lower incidence of myocardial infarction, but when they looked for the risk factors, they found out that in women, triglycerides were significantly associated with a higher risk for CHD than in men. And I would say these two publications, the reason that you see all these arrows, that in fact this was the birth of kind of the reference levels, the 150 and the 250 as a cutoff point, abnormal or pathological triglyceride levels. 30 years ago, when I was sitting, still in the medical school, or a little bit, even longer, we learned that the cutoff for triglycerides was 250, but then at that time they were telling us also that LDL was the cutoff 190. So, but you see, if you look back to these figures, it's more logical that the whole problem starts, especially for the triglycerides, 150. The Helsinki heart trial was kind of the trial, and you're all familiar with it, is the trial which is designed before the 4S. Fibrates is coming out. The Scandinavians want to do the 4S trial. The Finnish never get very well accepted by the Norwegian, the Danish, and the Swedish. So they wanted to have a little bit their own trial, despite that the Finnish have the highest incidence of that whole northern continent regarding the LDL. The reason why I bring that slide, because the main goal was of the Helsinki heart trial to answer the question, does Fibrates reduce cardiovascular morbidity and mortality if you lower the LDL? And you know the answer. CVD mortality, the answer was yes, total mortality, no. But I have put that slide in that it shows very nicely. We all know that Fibrates lowers much more the triglycerides than the LDL, that in a ratio, because they looked in function of the triglycerides, and the cholesterol over the HDL ratio, we all know from Framingham, less than 5, lower risk for a CHD, higher than 5, higher risk. And you see here, if your ratio is more than 5, and you give Fibrates, then the risk reduction is not so much. If your risk ratio, cholesterol over HDL ratio is more than 5, and you have triglycerides more than 200, then your risk reduction is 45%. So if I may summarize, or the interpretation of the whole Helsinki heart trial, it was positive for CVD morbidity and mortality, but I think it was majorly in the group still with a pathological cholesterol over HDL ratio, and it was mainly due to lowering the triglycerides level. But I think it never received attention enough, because of course the Helsinki heart trial was blown away by the 4S study. The Simvastatin Scandinavian survival study, of course no other Scandinavian country wanted to say any word anymore regarding Fibrates, and on top of that, Fibrates was an American fibrate, despite that the French, they got their phenofibrate developed in Lyon, and that was over. And Fibrates was not allowed to be prescribed, was not reimbursed anymore too. The Copenhagen study was again looking in male population free of overt disease during 8-year follow-up, and then again after adjustments for everything, that still if the triglycerides were more than 40 milligrams per deciliter, still a very high risk for CHD. And so you have seen in my agenda now the whole story starts. Should we measure the lipids, fasting or non-fasting? And I think a very nice paper came out that never received a lot of attention from Bansal in the JAMA, where in fact they go back to the Women's Health Study and they figure out the predictive value of the high versus the low triglyceride levels as future cardiovascular disease events in function of HDL. And then they say, let's sort out if the triglycerides were determined on a fasting or a non-fasting blood specimen. And what you see here at the bottom, whatever you do, that in fact, if you adjust for nearly everything, but you look for the non-fasting triglyceride level, that in fact is much more predictive. So that was a pressure to try to launch the idea, if you have your lipids done, please do not come fasting.
Could it be a product of high elevated insulin levels?
Well, you raise a very important point. I'm very happy that you tell it, because that is the whole issue. Diagnosis of diabetes, triglycerides, insulin resistance. I think they should stop, ring the bell, and somebody with a glycemia of 126, because we see all these people running around pre-diabetic or just over the edge, never under control, a little apple around their umbilicus, and then if they are 40 or 50, then they do all these CVD events. I think it would be much nicer, but the study needs to be done just in the HOMA and the insulin multiplied by glycemia, or even insulin multiplied by triglycerides. Paul Ridker, when his CRP was fading out, he tried to launch that idea, but I think nobody wanted to hear it because the CRP is still going on. But his cry to go for a non-fasting specimen, is forgotten or.
What is the normal non-fasting? It depends on what you eat, right? And how would you, let's say you non-fast and you drink a French press coffee and have some whole milk or something, you're going to have your triglycerides and everything will be high just by what you take.
Or just in the evening, a pizza with 2 glasses of red wine. Even if it is a Schwab. $3 than Trader Joe. Triglycerides would be elevated. That's the whole, that's the reason why Paul Ridker never could move forward, because they asked him what would be the cutoff point. I think I have not put that slide in, but the Canadians in Quebec and Montreal, they have also, where they do a kind of a test where they, like a glucose tolerance test. And then they will also measure the triglycerides. I think your point is very well taken. I think the whole issue is that it took already decades to say from the 200, you have seen the PROCAM study in Munster, then the 150, and then the Framingham. Also, the Women's Heart Health study also came down to about 150. There are now about 3 papers, about 1 American and 2 European regarding the triglycerides. They still have no good agreement. Plus, the other fact is that the US is the only country which uses milligram per deciliter. All the other countries is millimole per liter. So that's the other problem. If they convert, I think it's not a problem because you have all these converters now and calculators like cholesterol. It's about 40. but that could be an obstacle. And you see here, I have projected that slide, the Copenhagen study, where in fact I go a little bit further. The non-fasting triglycerides now in minimal, significant for myocardial infarction, ischemic coronary heart disease, also based on the emerging risk collaboration was CHD, ischemic stroke. In about the two trials, the Copenhagen City study and then the emerging risk factors collaboration, that it's very interesting that all-cause mortality, ischemic heart disease, and stroke, that non-fasting are also linear. It's very interesting because your point is very well taken, because you say, what would be the cutoff point? If there would be no kind of a pathophysiological mechanism, you would never see kind of even non-fasting, you expect a little more bumps on that curve, and it was not the case. So regarding the causes, I think cardiometabolic syndrome does not need any words. Alcohol intake, we all know, but I think if you see people, especially youngsters, be careful what you write in the chart, because you have these people with the congenital triglycerides who never receive attention anymore because they came in and they say, I'm drinking during the weekend 2 or 3 beers. Triglycerides were about 2,000. And then you have that sticker on your back, I'm an alcoholic. And their gallbladder is taken out at the age of 25 years old. And they never get the kind of a treatment. We may not forget, and that's the important issue, that these high triglycerides will also increase your coagulation factors. That's the reason with high triglycerides you are much more prone for blood clots too, so even in other systems. The carbohydrate, then renal failure before your kidney function goes down, triglycerides go up, and then the classical anti-rejection medication, rapamine. You have all faced these patients. Estrogen, pregnancy or contraceptives, also one, and then in HIV, the protease inhibitors. And then some medication for acne, but they are more used, the vitamin A, not the supplements, but I have seen a 38-year-old gentleman working in sale in a car, in a car shop. He was taking so much, he ended up with a stroke. The triglycerides were about 2,400. No history of the family. He didn't even mention that he took that for his acne. And then, of course, he was so disabled, he stopped that, got a little bit back, more acne, and when we checked the lipids, it was much lower, and then it came out. So the reason why, so you saw the fibrosils, then you see over time nearly no attention anymore to treat these triglycerides. And then the question is, what was the phenomenon? You may not forget that the statins were very much a revolution in treating of coronary heart disease. And so everybody ignores triglycerides. However, if you look to the papers in the beginning of 2000s, then I think it's clear that statin therapy does not eliminate the whole cardiovascular disease risk. And so that was the heart protection study, the collaborative group. And then Frank Sachs from Boston, they write 2 very nice position papers, because in the heart protection with simvastatin, you see low and high triglycerides, despite you have reduced the risk with the statin to about 18.3%, if the patient still has triglyceride, high triglycerides, above 150, the risk is even with 5% higher. And the same was true with the CARE trial, where the whole issue is if you give PRavastatin in these people intervention and the lipid trial 2 PRavastatin in patients with chronic ischemic disease. So triglycerides were ignored. And in the PROOF trial, PRavastatin or Atorvastatin, the landmark trial which brought the LDL down, you see here again that the impact of triglycerides beyond the LDL cholesterol, because if I ask you improved, everybody say that was the moment that the whole medical world went in atherosclerotic disease patients from 100 to 70. But however, if you see the difference, what was saved if the triglycerides were more or equal than 150 or below, you have a 16.5% versus 11.7%. And you see here the references. So what are the mechanisms of action? We'll go very fast over it. Statins in general do not change the triglycerides so much. You see here in all the textbooks 5 to 30%. I think you're aware that rosuvastatin always makes the war that their statin, Crestor, is better than the others to lower triglycerides. Do not forget that after 3 months of statin, there is nearly no difference anymore between atorvastatin and rosuvastatin. It's only marketing. In fact, after 3 months, rosuvastatin got lower triglycerides than atorvastatin, but you do not start statin only for 3 months. Ezetimibe is out now, triglycerides 2%. Bile resins can increase triglyceride levels, so do not forget for that, but it's very rare that you will use it. The niacin, mainly given to increase HDL, but it can be effective to decrease the triglyceride levels, because then the VA hit. You're familiar with that study, but there was a study that to increase the HDL was positive. Triglyceride levels were significantly decreased. Theoretically, if you have no solution anymore to reduce the triglycerides, that could be the last chance. After fish oil, after fenofibrates, niacin, that would be my third choice. But of course, the question is, do you reduce morbidity and mortality? We do not know. We know when we use it to lower LDL cholesterol, we don't. Fenofibrate, I will not go in the mechanism. It decreases LDL 5 to 20%. You have the two, the fenofibrate and the hemfibrazil. Hemfibrazil, you start with 600, you go to the max 1200. Fenofibrate, you have the 54, you have then the 145, you have the 154. In the US, people start to shake when they go above 154. Now you have all these pharmacists who do the consults with their patients. If you go above, you receive these epic messages, you are too high at a dose, then the fight, they do not look to the triglycerides. If your patient still has 600-700, go more. What you need to do with fenofibrate, once you start, look first to the creatinine, because your kidney function, your creatinine will go up, kidney function will go down, If the GFR is lower than 60%, do not think my phenofibrate, the sky is the limit, because the kidney will be the zero. So you reduce the dosage, and that's the whole issue. If your kidney function is going down, your triglycerides go up, your HDL goes down, and sometimes nephrologists, if it is a cardiovascular path, they send them to cardiology, they cannot handle the risk factors, and then people say fish oil or phenofibrate, but if a patient is, for instance, on rapamune, is a kidney transplant and so on, and goes in rejection, and then is walking to the dialysis, but not on the dialysis, develops a pancreatitis, then they say what to do. Be very careful. If the GFR is below 45, go only with about half of 54. So that's the key point. If you use phenofibrate, you have not to be afraid, but adapt the dosage in function of renal function. I think in the future, we will see that phenofibrate will be much, much more utilized for the following reasons. With the cardiometabolic syndrome, there is a fatty liver, risk for liver transplant. Phenofibrate reduced the risk for fatty liver. They reduce inflammation. They will have less oxidative stress. You see that the uric acid will go down, but not so significantly, but that has not well established. And there's also less risk for thrombosis. You would say, Duprez, show it me, because I have in my pocket the field study, perhaps about 10 years ago. The field was the Australian trial. Phenofibrate, a French product, developed in Lyon. Colhoun, the lipid specialist of London, she was ready. She wanted to work with phenofibrate, but the UK looks more to the US than France. They live still with the idea of the Centennial War, which worsened after June the 23rd of this year when they vote for the Brexit. So they give the whole trial to the Australians. You see here nearly 10,000 people, type 2 diabetes. That was the total cholesterol. Phenofibrate 200 milligrams once daily, because the dosage of phenofibrate in Europe is 200 and 400. Primary endpoint is CHD, death plus non-fatal MI. Inclusion, I will not, because you know it. Here is the baseline characteristics. I think this is like the Accord. Triglycerides in type 2 diabetes, they are more than controlled. Do not forget, we are in 2005. There is less a problem of obesity worldwide, and then in Australia too. At that time, the HDL level is still discriminated female versus male. What do we see now? The 4S is published in 1988, in the 90s, you just saw. So physicians start to throw in simvastatin. And you see here the percentage of the patients, 70% in the placebo group, 8% in the phenofibrate. For unknown reasons, they could not control it anymore. And you see in people with prior CVD, there was much more drop-in than in the primary prevention. You see the effect of the lipids, triglycerides, total population minus 30, what is expected. Phenofibrate minus 21%. If patient was not receiving a statin, still LDL minus 17, triglycerides minus 25, and where other lipid lowering therapy was started, LDL of course much lower, triglycerides minus 22%. And so the conclusion of the field was, does not meet the primary endpoints, and the phenofibrate, the reduction is 11%, statistically non-significant. So, and this is the start that everybody says, fibrate, forget it, it does not protect anything, except the little bit, the secondary endpoints and the need for laser therapy. The Accord trial, you are familiar with that. The reason why I put that slide in, because you see here the primary prevention trial with fibrate, and the secondary, the VA hit, but the VA hit was designed to increase HDL. The basofibrate, mainly done in Israel, you see the risk, VA hit. So yeah, strongly significant if you lower triglycerides. Basofibrate, but it will never come on the market, just 0.3, very weak for trial. It's like the Improved trial, the field study, and then the other study, 71%, 19%. So where do we stand now with the trials? I think for phenofibrates, we still need to have some outcome trials. I will give you kind of a summary, but I think I forgot to copy that, I think, in that slide. We have fish oil, there is Lovasa, there is Vascepa, and there is the fish oil by AstraZeneca. It's N-omega-3 fatty acids. What do we have? With Lovasa, no outcome studies regarding endpoints. You could say, Duprez, why are you using it? Because N3 fatty acids, purified fish oil, much more effective than over the counter. Because over the counter is you go to the fish market, you put all the garbage before they sell the fish in your blender, and you will have some fish oil if you come home during the evening. So, but the concentration of N-omega-3 is relatively low. Lovasa is it's now generic. Still, some healthcare assurance puts it in second tier. Some in third tier, I do not know why. We have no answer. Vascepa, the reduced trial, have you heard about that? Is patients with coronary heart disease. 8,000 need to be enrolled. Placebo versus the Vascepa. I would say the FDA have brought the company in a difficult scenario. It's a very small company and weak. I think they are very silent. I think they will be forced by Wall Street to report at least when they have 50% of their patients enrolled. It's like the Improved trial. You do not hear them. Of course, they face the whole catastrophe that all their medications for multiple sclerosis and Parkinson's are now in a garbage can, and that their bank account is empty. So the FDA told them you can only enroll people with CHD when the LDL is below 100 milligrams per deciliter. So I expect that the study will not be enough powered to reduce CHD risk. Then the third, that will be a landmark trial, the strength trial, coordinated by Steve Nissen, 13,000 people, a little bit more liberal. Diabetes, CHD, and so much, and I'm surprised that Steve Nissen is so liberal, because even you can include the diabetic patients when the hemoglobin A1C is below 12. I would have never expected that he would allow that. Because if you start to work in a trial, sometimes you see that diabetes, other parameters are better controlled because they have to come over and over again for the follow-up. They have now 6,000 enrolled, so they have still 7,000 to go. That's the omega-3 fatty acids. That will help us if there is outcome, yes or not. You have a Japanese trial, but the Japanese are a little bit, they look for arrhythmias, because there is always the rumor of fish will reduce the risk for ventricular arrhythmias or AFib and so on, but so these trials are small and not very well controlled. Then you have the PPAR agonists in development. Then you have the ApoC3 antibody. I think that's a company who looked over their shoulders to Amgen and Sanofi. They want to have an antibody. And then in the New England Journal of Medicine for the extreme hypertriglyceridemia, they have a kind of an anti-statin therapy. So you will see the next decade is a huge explosion of medication to lower the triglycerides. You do apheresis in case triglycerides are still 2,000 or 3,000 and you cannot control it. But at this moment, we have no evidence lowering the triglycerides. That's what we have, reduces morbidity and mortality.
How do you manage the risk of elevated PKs and
if you do not use Fibrates, that's a very important point. Fibrates over statin will increase your risk for muscle pain 84 times. If you use fenofibrate, maximum is 3 times. That's the you just need to be careful if you would use PRavastatin, which is the only statin cleared by the kidney, and fenofibrate, because your kidney goes down, PRavastatin goes up. I think most of the Fibrates, I don't know, it was a fellow, and it was a Jeremy, that we got one that is PK. Not elevated, but then I didn't believe it. I will just give you a hint. If you have a patient on statins and the PK is continuous and they do not complain too much about muscle pain, look here. Look in the snake box. Because that person, I told him you need to go to a neurologist. About 3 weeks ago, he had last was diagnosed. He got about 6 months ago, 3 stents here. And then he was put on Lipitor, and he finally, they did not have any CK before, and CK was about 4 or 5 hours, and then, most of the people thought it was just a statin. But I think fenofibrate very, very rare, yeah?
my understanding from what I was learning was that you have high triglycerides, low HDL, but that's a marker for more atherogenic LDL. Wondering when that's true, and number two, if when we're changing, altering levels of triglycerides, not affecting the atherogenic LDL as much.
But your first statement is absolutely right, because when I was putting the slides together, I intended to say something on the part, because if you have very high triglycerides, you will have a low, it's the yin yang. You will have a low HDL, and your HDL will be more dysfunctional, but with high triglycerides, you have much more IDL, VLDL, and your LDL will consist more about small particles. Which are more atherogenic, and what you, if you lower the triglyceride, you change the particle size in the meantime, because still these absolute concentrations are not so,
So that'd be looking at, like, if you bring down the triglycerides, are you indeed altering the LDL in a more positive manner?
Yeah, with the phenotype, you will change your LDL, because the whole fibrosil counts, but The whole Helsinki heart study was designed to lower the LDL. Nobody, and I think it was the last draft of the, I forgot the company because it was bought by Pfizer, but they got also Quinapril, the ACE inhibitor. I think inhibitor was owned by White. And then they wanted to do a huge trial because they felt the heat of all these statin companies, and that's the reason why they sponsored the Helsinki heart study. But then I put that slide in. If you look to the Fibrates, it reduced cardiovascular morbidity and mortality by 20%. But then what you see is if the triglycerides are below 200, hence Fibrates was not so different than placebo. Okay, thank you very much.
Thank you.